Thanks again for everyone in joining this APSC Cathlab workshop. Today's focus is on small vessel coronary artery disease. The date stamp today is the 15th October on a Friday, 3 p.m. Singapore time. This APSC event is hosted at the National Heart Centre Singapore, endorsed by the Singapore Cardiac Society, the Asian Pacific Society of Interventional Cardiology, EBAC and SMC accredited for CME points in collaboration with Medtronic. My name is Jack, a cardiologist based out of Singapore, your chair and host of today, the immediate past president for the APSC. And we're very happy and privileged to have this event hosted and organized out of the National Heart Centre Singapore. The first speaker for today is Datuk Dr. Rosli Muhammad Ali, Interventional Cardiologist at CV Sentral, Kuala Lumpur. He's going to talk to us on overcoming the complexities in small vessel PCI. Our second speaker is Professor Azfar Zaman, Clinical Professor of Cardiology and Director of the Cathlab at the Freeman Hospital and Newcastle University from the UK. He's going to speak to the ideal case for DCB and update in 2021. Our two Cathlab operators today are my bosses, Professor Aaron Wong and Professor Lim Sutek from the National Heart Centre Singapore. Our panelists will include Dr. Joshua Loh, Senior Consultant Cardiologist at Capital Heart Centre, as well as Professor Quang from Vietnam National Heart Institute, Bach Mai, Hanoi, Vietnam. Our panelists include Dr. Himanshu Gupta at the Advanced Cardiac Centre, Chandigarh, India, Dr. Moonpat from the Cardiology Unit, Department of Medicine in Thammasat University, Thailand. And our coordinator today is Dr. Ke Yen San from the National Heart Centre, Singapore. Dr. Huang, he from Korea sent his apologies. I think he is caught up with an urgent case. He may not be able to join in today. A pitch for upcoming webinars on the 12th November. We have APSC live transmission on imaging from simple to complex PCI. We will focus on teaching on OCT guided PCI. 27th November, we have a transcontinental chip case sharing, chip with or without mechanical circuitry support. A disclaimer, this content is copyrighted by the APSC. The views expressed are those of the faculty members alone. This webinar is made live stream via Wonder APSC as well as YouTube pages. CME points will be submitted for those who are connected throughout the whole duration of the webinar. You will then receive your certificate of attendance upon completing a survey by email. I want to quickly state the learning objectives for today. One, we want to share the insights, tips, and tricks on the current advancements in the management of small vessel coronary artery disease, a very tough subset of patients to manage. We want to learn when to stent and possibly when to consider DCB therapy. And we want to avoid the pitfalls so as to optimize either stent or DCB therapies. So let's get started, and I would like to invite Dr. Datuk Rosli Muhammad Ali to give the first talk of the day.
Thank you very much, Jack, once more for the kind invitation. Are you seeing my slides right now?
Yep, full screen.
All right, yes, hold on. All right, so the complete slide. Okay, so overcoming the complexities of treating small vessel disease. And I must say that when I did a literature search on this, there is still a dearth of data as compared to other lesion subsets. So obviously it tells you that there's lots of work that needs to be done. The first issue is that there are a couple of issues, of course. The first issue is the definition. The definition itself is unclear in most instances. For example, Agostoni in meta-analysis took less than 3.0 mm liberal use of what is defined as small vessel disease. Basket small 2 used less than 3.0. The Dutch peers noted that they define as less than 2.5 because this actually stratifies the risk of target lesion failure. Anything above is lower, anything below or less than 2.5 suggests that the risk is much higher. And there is such a thing as very small vessel. So I think if you look at the literature now, what is considered to be small vessel is any lesion less or equal to 2.75. And for very small vessel of less than 2.25 mm, that's considered as very small vessel. And obviously that the challenges is going to be much higher. Now, small vessels may not actually be small. And this is something that we have seen, especially when you when image the vessel. So when you have a body mass index, which is small, for example, females, small tends to be small. But we have seen a lot of patients, for example, diabetics, where small may not actually mean small. So, and diabetes in Malaysia, PCIs occurs in about 1 out of 2 patients are actually diabetic in Malaysia. So one needs to be careful in terms of what one needs to consider small and treat them appropriately. Now, the incidence of small vessel disease is not insignificant. 1 out of 3 patients with symptomatic CAD tend to have small vessel disease at the same time. The incidence is much higher in active smokers, chronic disease, diabetics, as I mentioned it. So it is not insignificant. And when you have small vessel disease, you find that they tend to be associated with diffuse disease. This is one such lady who's a diabetic, 47 years of age, that I just saw yesterday. And as you can see, from very distal to mid segment, also having large vessel disease, the left main stem being involved at the same time. And it is also not uncommon for you to see that the vessels are so diffuse that in the end, optimal medical therapy is the only therapeutic option which is available in these patients. The so-called, what some people term it as end-stage phase of the coronary artery disease. So this is definitely a challenge when you want to treat these patients. And when you think about cabbage as a treatment in coronary artery disease, it also poses a challenge for patients with small vessel disease. You know, some of patients or some of our friends say that, it's too small, I can't grab that, can you please do it? Some of the other people would just say, hey, it's probably underfilled and it will probably be larger. It might not be so. What is small can actually be small when they open up the vessel, when they open up the patient. Now, there is a much higher risk of technical failure in MACE, and this is an example of a paper that you can see. If a vessel is small, 1.0 mm or less, then an in-hospital mortality is about 16%, whereas if the target vessels are large, then the mortality is very low. Now, what about us? I mean, in patients requiring PCI, it's the same thing. You find that the complication rate is much higher. Periprocedural MI is much higher. Perforation and cardiac tamponade can also be higher. So we also face the same challenge. But what is known is that with stents, especially drug-eluting stents, these are old data, and we have got to dig up the old data to try to show that DS was much better than BMS. And these are serious and serious sirolimus-eluting stent in the SMART study. If you recall, the TLR was low as compared to bare metal stent. In fact, if you to look at the SES SMART, where the vessel was deemed to be very small, the TLR rate was was actually in the single digit. We also know that different DS gives different outcome. In this case, an everolimus-eluting stent versus paclitaxel eluting stent, the everolimus-eluting stent did much better than PES with regards to target vessel failure. So once again, it does make a difference what type of stents you use. Now, why is it so? Is it because in small vessels, you tend to get lower initial lumen gain, or is a problem is due to greater late lumen loss? This is just a cartoon showing that on the left side is small vessel, on the right side is large vessel. And if you to treat the large vessels, you tend to get a much higher initial lumen gain. And therefore, when you have any late lumen loss as you follow this patient up, this is going to be much more pronounced in the small vessel as compared to the person when you're treating large vessel. Now, the question is this true? And the answer is yes, it is. This is a paper showing that a one-year outcome in treating different vessel diameter, looking at small vessels of less than 2.8 a medium-sized vessel, 2.8 to 3.2, and large vessel of more than 3.2. And you find that in event survival rate, the angiographic restenosis was much higher in patients with with small vessel as compared to intermediate and large vessel. In fact, what is important is that the late lumen loss was no different when you treat small or large vessel, no significant difference. So it does come up to the fact that when you have a person with small vessels, you tend to get late lumen loss, which is going to be more pronounced and will affect flow as compared to large vessel. In fact, what is interesting is that the most important or powerful predictor of angiographic restenosis is actually the vessel diameter. For every 0.5 mm decrease in the vessel diameter, that can amount to a 60% higher risk of restenosis rate. So this is the issues that we face when we treat small vessel disease. What else can we do? Thicker and versus thinner stents. Interesting. Paclitaxel eluting stent, the Liberté stent, which was much thinner than the Express stent, which was thicker. And this showed that the thinner stent was much lower in terms of the 9-month restenosis rates and 12-month TLR rate with the thinner stents as compared to the thicker stents. So all these things you will have to think about when you choose a patient and when you choose something that you want to treat the patients with. Now, it is not just that. Perhaps it is also important for us to try to demand or rather encourage the companies to make DES for small vessel disease. This is one such study, the Resolute Onyx extra small vessel study with a 2.0 mm DES. This is a multi-center prospective study with a 1-year follow-up. And you find that the TLR rate was very low at 2%. And there was also no stent thrombosis in this group of patients. When they had a look at the pool data of Resolute pool data for small vessel versus larger vessel, and we found that there was a slight numerical increase in the extra small vessel, but it was not statistically significant. And this was carried out to 3 years. In the subset analysis of diabetic and diabetic in small vessel analysis, there was also no significant difference between the diabetic subgroup and also the non-diabetic subgroup. So I believe that for small vessel, one needs to consider stents which are purely designed for small vessels to be able to get better results. Functional assessment in small vessel disease, I feel, is also very important. When you look at a vessel which is large and you find a stenosis, the error of assessment of severity is going to be much lower than when you have a vessel which is smaller with stenosis. You tend to overestimate the degree of stenosis angiographically for small vessel disease as compared to large vessel. And this is under the Phantom trial, where they assess FFR and looking at stenosis in small vessel disease. 30% of stenosis which were deemed significant by angiogram was truly significant. The other 70% was not significant. So this is something that you may want to consider, especially in difficult situations. And obviously, the functional assessment in this case does help to improve decision-making outcomes. And one such study showing that FFR-guided PCR showed a much lower MACE rate by almost half as compared to angiographic-guided PCI, and the cost is also much lower. Drug-coated balloon. I'm not going to steal the thunder from the second speaker, Dr. Zaman, and I just want to, when you look at the literature, you find that when you click in small vessel, drug-coated balloon comes up very frequently nowadays, and it tells you the way that the practice is going to go in the future in determining what is best to be treated for small vessel disease, and drug-coated balloon will feature significantly. Just want to share with you one such patient. This is a patient with a young person with CTO in a mid-LED. You can see that in the mid segment, there's also severe stenosis. And at the same time, the large diagonal branch is also severely stenosed. And this was treated with POBA, with a scoring balloon. Subsequently, this was treated, this was the results after. And you can see that the vessel was diffusely diseased right until distal. The distal segment was treated with drug-coated balloon. And in the end, what we did and what we had was a hybrid combination of DES and DCB. In the proximal and mid segment, it was treated with DS because of flow limiting dissection. Also in the diagonal branch, but in this distal segment, it was treated with drug-coated balloon. And that is the results following a restudy at 9 months later. And you can see that the areas that is treated with drug-coated balloon has actually healed and has actually expanded. There's vessel gain, luminal gain in the area that is treated with drug-coated balloon. And obviously at 6 months, you tend to see that the results in the DES is still good. So I believe that in the future, a lot of our patients can actually be treated with a combination of DES and DCB, especially for small vessel. So to conclude, ladies and gentlemen, a small vessel disease is still a not well explored clinical setting. It does require more extensive research into indication of treatment and also in the optimal methods of myocardial revascularization. So watch out for this space. And I think if we're going to see a lot of patients, especially in Asia with small vessel disease, we need to really consider how best to treat this patient. Thank you very much once again for the invitation. Jack?
Thanks, Rosli. Again, you gave us a lot of food for thought and a lot of points to discuss around. So maybe I would like to ask Dr. Zaman first, so they can preempt us on his lecture. Rosli talked about small vessel definition, which I'm always trying to grapple with. In my mind, small vessel definition is less than 2.25, but in a lot of the studies, it was defined as less than 2.75 or 3.0. Is that how we should think about small vessel disease versus large vessel disease?
Yes, my feeling is, having read the literature, you're quite right that there is a spectrum, but it seems to me that people are gravitating now towards the 2.75 and below. And I think if we stick to this definition, it's important we have that so that we have a universal definition, and then we can apply this to all trials and results from all trials.
Does length matter in sizing? For example, when you say small vessel disease, are we talking about just less than 2.75 and how many length for the vessel before we say?
That is a really good question, because where are you measuring the 2.75? Because most vessels taper. So are you measuring the 2.75 at the proximal extent, or are you measuring the 2.75 at the distal extent? And once again, I haven't read any definition of this, but to me, in my own mind, I see 2.75 as the largest diameter of whatever length you are measuring, so i.e. at the proximal extent, because distally, likelihood that vessel is smaller.
So maybe I can get Kwang to jump in here. Do you think that is in your mind the definition of what we're talking about today, small vessel disease? Kwang, please.
To me, it's as in the routine, we consider like less than 2.5, something like a small vessel disease. But I agree that with Zaman said that it is on the literature, we consider like less than 2.75. But to be honest, into the practice, when we consider the small vessel, it means we consider the drug coating balloon rather than stent, and then the small size is more prominent. So I think that 2.5 is the cutoff for that.
Yeah, I think everyone has their own personal cutoff. My personal cutoff is something that you don't want to put in a stent, is small vessel, but it is not supported by literature. I'd like to jump to Joshua now. So you have a small vessel, let's say it's 2.25. Do you think then the type of stent you implant makes a difference in terms of the strut thickness, and is there any preference in terms of small thin strut stents or ultra thin strut stents in those cases?
Yes, I think the current literature does suggest that the thinner the struts, the less risk of future late loss and improved outcomes later on. So especially so in small vessels, because they can't tolerate the late loss well. I mean, if you have a 2.0 vessel and you have a late loss of 1 mm, that's already half the diameter gone. As opposed to a 3.0 vessel and you have a late loss of 1 mm, and then you still have more than 70% lumen diameter. So small vessels do not tolerate late loss well, and so I would favor going for the ultra thin strut platforms that are currently available. And of course, it also matters that with the current generation stents, most of them have very good drug elution properties with highly compatible polymers.
So you favor a thinner stent strut for smaller vessels.
Certainly.
Yeah, Gupta, the recent ESC guidelines last year, they defined a high thrombotic stent type. They said more than 3 stents, more than 60 mm, bifurcation, but they don't quite mention small vessel. So if you do have a small vessel in your mind subset, what is your preference for the DAPT regime? Is there anything different you do? Or do you think that this is not relevant?
Thank you so much, Prof, for the invitation. Yes, small vessel disease, I believe, is very common in our practice, and it's the last frontier that we really don't know what it is, what we should do. If you do imaging, sometimes what you think small vessel, it is positively remodeled and the vessel is actually 3 millimeter. But what is worrying is that it is so diffuse that it goes up to the apex of the vessel, whether it is the PDA or the LAD. So even if you think that it's not a small vessel, you can stent, but there is no landing zone. So actually, you need to treat it differently. So of course, there is no good answer, especially if the small vessel is calcified, then even the DEB doesn't work because you have a lot of dissections after the balloon. So it's best probably to leave it alone. But yes, whenever we have small distal runoff disease, then we would like, in my own practice, I would, especially if the patient is diabetic, which they mostly are, to put them on prasugrel or ticagrelor in relative to clopidogrel. So give them stronger antiplatelets, even if they have non-ACS setting. I mean, even if they are stable angina setting.
Thanks, Gupta. The last question, perhaps, Munpet, is that we keep hearing that the small vessel may not be small. In your experience, when you do intravascular imaging, how often is that the case? And why? What is the pathophysiology of that? And how is it best treated if you see this negative remodeling?
Thank you for your question. So in my experience, because I use a lot of intravascular imaging in my practice, what I saw as a small vessel disease, so many times it's not actually small. It's like a diffuse disease, diffuse atherosclerosis. So usually, if I know the true vessel diameter, I usually treat it like a big vessel with the diffuse disease. If I can prove that it's not small. So many times I use the hybrid approach like Dr. Rosli used. I put the stent in the proximal part, and for the distal part, I use the DCB to prevent the edge dissection for the plaque. But in my experience, many times it's not small indeed.
It's just diffuse disease.
Yes.
Rosli, can I ask one last feedback from you since you gave the lecture? How often can you then differentiate this on CT angiogram before the cath? Can you tell that it's actually not small, or you can't?
I'm not sure, Jack. I don't do CT, so maybe someone else. But okay, coming back to that angiographically, this is my own personal experience, all right? It may not be true, but I find that for distal, for LED, for example, distal 1/3 of the vessel, if it's small, it tends to be small, but not for the proximal. But for the right is different. You think it's small, but you've got to be careful. If the circ is small, and you feel that the right is dominant, you can bet your bottom dollar that the distal vessel is not small, it's large. That's my own personal experience. I would love to hear from all of you, but I don't know the answer to your question.
Thanks. I don't know as well. That's why I asked you. So we're going to go to the Cathlab now because the case is exactly what Rosli talked about. And then we can use the case to discuss around your opinions as well. So can we go to the Cathlab to show my bosses here? So we have the operators, just to say hello before we jump to the case. So they are busy working. We have Professor Aaron Wong waving to us, as well as Professor Lim Sutek, who looks very busy, so we won't distract him, and Rose, who is assisting. So I'm going to just interrupt them to just present the case first. Then we'll go back to the discussion. Then we'll jump back to the lab. Aaron, that's okay with you, right? I'll show them the case first.
Sure. Jack, sure.
So panel has some advice for you. So thanks again, Sutek and Aaron, for doing this case. And the case is actually a 44-year-old male, very young, risk factors, previous smoker, and also has chronic atrial fibrillation CHEST score of 4. This is a clinical presentation. So last year, just before COVID struck us, he presented with an ACS and STEMI. He came in with an EF of 28% and CAF then showed triple vessel disease. At the cardiac MRI, because it's quite young for this degree of pathology, which shows a small area of subendocardial infarction in the basal inferior lateral wall, suggestive of IHD superimposed on some form of cardiomyopathy. But the patient then declined any further intervention and dropped out from our radar. He came back in September this year, almost 1 year later, and we had a recap showing the same triple vessel disease pathology. EF is 27%. Had a heart team discussion with limited benefit of CABG due to the diffuse nature of disease, and he then opted for a PCI. PCI was done earlier this month with overlapping almost full metal jacket in the LAD. These are his labs: normal hemoglobin, normal renal function, cholesterol LDL of 2.17 could be better improved. DM relatively well controlled at 6.6%. His ECG showing atrial fibrillation, some loss of R wave in the anterior septal leads, but quite well preserved R wave progression in the lateral leads. Chest X-ray showing some dilatation on the borders, shows what looks like atrial dilatation with some borderline cardiomegaly. And this is his echo picture showing poor EF, and I'm sure there's LA and RA dilatation. This is an angiogram of his LAD pre-intervention diffuse disease. You can see a small branch of the circumflex also disease, and then had overlapping stents, almost full metal jacket in the LAD. So he has segments of disease in the LAD segments, and this was stented with 3 overlapping drug-eluting stents. Today's focus then is on this right coronary artery, so I'll get all my panel to have a close look at this images. I'll take a pause, let you have a quick look. There's 2 views, but the money shot is the next one. So you have a 44-year-old gentleman, diabetic, EF 20% already fixed LAD, and you have this right coronary artery with both proximal as well as distal outflow disease. The target for today, small vessel, is the distal right. And I'll just hold this picture on while we get opinions from everyone. So maybe we'll start with Rosli. Is this small, big, diffuse?
This is small. It's ostial of the PD, and I think it extends a bit to the distal right, and then there's a large PL branch which is severely stenosed and diffuse. Yes, so the answer to the question is yes, this is considered small, very small.
And Dr. Zaman, will you disagree? And is this for DCB or DES?
Yeah, so I completely agree. And one other thing we should say is that there are geographical variations in the size of the coronary artery, and this may be the reason why I say 2.75. But in the South Asian population, you may well decide it's 2.5. But I think I agree that PDA is small vessel and ideally DCB.
So Dr. Zaman says DCB in the distal outflow, and maybe Dr. Munpet, is this one of your hybrid approaches for stents proximally and DCB distally? Do you think that is the optimum combination here?
In this case, I think both RPD and RPL are significant because from the CT data that they measure the myocardial mass at risk, they found that if the length of the branch is more than 63 millimeter, no, 73 millimeter is usually supply more than 10% of the myocardium. So I think both branch are more than 73 millimeter. So I want to treat both branches. But for the for the PL, I think it's quite small in the distal, and I think if we put the DCB, maybe if we put the stent, maybe we make the distal edge dissection. So I want to put the DCB in the RPL, but for the RPD, I think I would do imaging. If I can put the stent, I will do the crossover stenting from the RPD into the distal RCA.
Thanks, Dr. Munpek. I'd like to ask Gupta now, if you use imaging, is this an imaging case for OCT or IVUS, or you don't need imaging?
Thank you, Dr. Jack, and great operators. So they will have a good result, my teachers. So I think imaging is essential, but of course, IVUS, not OCT, because it's so distal and we have to inject a lot of contrast to get good images and clearance for OCT. So of course, IVUS. I think the proximal PDA is a sizable vessel, which probably we can stent across into the RCA, but first we need to predilate the distal PL, see what is the result of the predilatation, and then do IVUS. But of course, when we do IVUS after predilatation, there will be a lot of dissection, which will instigate us to put a stent. But if it is non-flow limiting, and the operator has reasonable experience, then probably DCB will be good for the PL, but a stent for the PDA into the right. But after imaging also, Dr. Jack, Prof, sometimes you get confused whether you should stent it now or not, because the vessel will be sizable, will be 2.5 or more. But then whether you stent at that point or not, because there will be some dissections which may not be flow limiting. So that is where the confusion comes in this kind of a vessel. But of course, with imaging, only the final decision, Prof.
Good point,
some say if the area is 3.6 or more, or 3.7 or more, the minimum lumen area, then even the dissection you can leave alone, because chances of occlusion will be less. So probably imaging will help.
So the challenge is to get good final MRI without dissecting it. I will go to Joshua. Joshua, can you let me know what is you think your strategy, and because of the atrial fibrillation, how comfortable you are to shorten all your DAPT here?
Yeah, I think this is a very challenging case, Jack, and certainly there is extensive disease in the distal branches. I'm not sure if the RPL is actually an interventional target, because it looks to me less than a 2.0 vessel, and it's actually extremely diffuse. But the RPDA certainly is. The problem is that because there is osteo-PDA disease, and whether you want to preserve that bifurcation. If we do want to preserve the bifurcation, then I will opt for just a DCB only approach, perhaps even both DCB in the distal RCA as well as the RPDA. Of course, imaging guidance would be important to optimize the outcomes, but I'm not sure also if there is a challenge in delivering the imaging catheter that distally and with small vessels, which often is a major limitation in the trials. And therefore, you see that imaging rates are actually quite limited in most of the small vessel trials. With regard to DAPT, of course, the patient would need anticoagulation. So a short course of DAPT is preferable. And we can achieve that if we choose a DCB-only approach, provided we have optimal POBA results for us to do that. Yeah, these are my thoughts. Thank you.
Very, very nice advice as well. So now we're back to the Cathlab. I think my bosses chose a very tough case to challenge themselves. So we'd like to hear from Aaron and Sutik what they've done, what their strategy, their thoughts. Aaron?
Hi, Sutik is running away. Hi, everyone. Welcome to Heart Center. Indeed, it was a very, very tough case. So we will just let you know what our strategy is. So just let you show the baseline angiogram. So this is the left side. Looks pretty good results. That was done about a few weeks ago. So this is the angiogram of the RCA, especially the AP cranial view. So we actually discussed extensively. So what's the option? The PDA definitely, at least 2.0 vessels or 2.25. We can stent it if needed, but there is quite a complex bifurcation lesion. And then the other one is the PL branch. There's actually a few Yeah, there's PL1 and PL2, and PL2 looks quite big. So we thought we concentrate on that one. That one is a bit too small to stent. So we initial plan is to POBA, and then if it got good results, then we will just do a DCB. As for the PDA, we thought instead of doing a complex bifurcation lesion, if the POBA result is good, we can do a DCB and then just stent across the distal RCA into the RPAV as a provisional type of bifurcation stenting. Yeah. So that's our sort of initial approach. Yeah.
Yeah, do pay attention to this frontal plane. I'm not sure whether you can appreciate this calcification at the junction, at the entry into the RPL2. Now in retrospect, it look actually at least moderately calcified. So our guide catheter choice probably is not so ideal in this situation. Yeah, but there is also a proximal RCA lesion that we didn't want to deep seat the guider too much. Yeah, with the post, of course we can do a side hole. There's also other option of anchoring balloon or using the guide extension catheter to help. Yeah.
So this is a femoral 6 or 7 French system.
6 French.
6 French.
And we previously discussed some form of imaging to help. And Gupta was thinking that OCT is not suitable and therefore IVUS. Do you think you guys are going to do IVUS here as well?
Yeah, we actually did the IVUS. Yeah. Yeah, we put in 2 wires, the run through into the RPDA and then the Sion blue into the RPL. Yeah. And then we did a pre-dilatation of the ostium of the RPDA with a 2.0 and then subsequently 2.25 non-compliant balloon because our cutting balloon couldn't get in. Yeah. Then after that, then we put then use the cutting balloon 2.25 cutting balloon. Yeah. To further dilate. Then with
this is Wolverine, Sutek, is that correct?
Wolverine, yeah, Wolverine. We thought we want to test out how trackable it is to the deletion. Unfortunately, it didn't go. I think probably it's the hand that's no good. Yeah. Yeah.
Anyway, we did a IVUS before the Wolverine because we managed to get through a little bit.
Yes, we show you the IVUS one. Yeah.
The IVUS one is from the PDA. PDA back, is it?
Yeah, it's not the PDA. This one is actually, it went in a little bit into the AV groove artery. So you see that this is in the AV groove, and then the 11 o'clock is a PDA guide wire. You see there's actually a 270 degrees superficial calcification, and the vessel there is about 3540. A lot of plaque here, right?
So this is one of the case that looks small, but it's not small. It looks very big actually.
This is it looks like it's a tactic segment there. You know, this is actually a PL branch actually. So actually quite big, but the distal are a bit small. Yeah. So the second.
This is a distal. This is a distal. The distal media to media is also about at least 3.5.
Yeah.
It's a little bit ectatic. Yeah. But the size is about the same as the one the distal RCA. And the length between the two segments is approximately 18 millimeter.
So maybe we call for an opinion from Rosli now. It looks quite calcified, Rosli. Do you think is cutting balloon enough? What do you think of the case?
Sorry, Jack. So just to explain, we didn't do a cutting balloon in this artery. We did a cutting balloon in the PDA.
Yes, I know that. Yeah,
correct. Yeah.
This is the AV groove, and you're cut into the PDA, which is what we saw just now. Yeah.
Actually, we did an IVUS run in the RPDA. Maybe we show the RPDA IVUS first.
Okay.
Yeah. This was as far as we could go initially. Yeah. This is about 2.75. This is the RPDA pulling back into the distal RCA.
Very short distance PDA
Very
because
short
we couldn't push through.
Yeah. Initially couldn't push through.
But
we have one more run.
One more run.
Yeah. This is after the cutting balloon.
Yeah. And this is indeed small vessel. Yeah.
A little bit distal to it. Then it's bigger now. Yeah.
You
this
gave
one
a lot. There's a lot of nitro that was given, right? Nitroglycerin.
Yes. Yeah. Okay. Initially, there was actually a vasospasm. Distal to the area of balloon dilatation. Okay. Yeah. So those were the information that we had so far.
Rosli?
Advice from you.
Yeah, my thoughts first, when I look at it, the PD osteum is significantly diseased. So just distal at the proximal PD, it's about 2.5 just now. And then as you pull back a bit more proximal, it tends to be bigger. Then the PL branch, I think at the osteo PL, even the disease, it doesn't look that significant. The one that is significant is actually the distal vessel. So I would still consider either a scoring balloon or cutting balloon. And even for the PL, I would still do a scoring balloon to try to get as good result as possible. You know me, Jack, I think for cases like this, I tend to use DCB as much as possible. One needs to be patient. One needs to prepare the vessel better. And now that you've got IVUS, if let's say you can, you can do a bigger balloon, then use a bigger balloon to prepare the vessel better, and then DCB it.
225.
Thanks, Rosli. Kwang, you saw that as well. Do you have any ways of doing it differently? Do you think it's still a stent case because the vessel size is actually quite big? So would you say stent is also reasonable or not?
I think stent is still reasonable. The issue here is we need to prepare the lesion first, and I should also consider the cutting balloon for the RPL as well. And then do the IVUS again and see, because after you cut and you prepare the lesion, the vessel size is quite big, and for the future, and I think I myself consider put the stent. For the distally part of the RPL, we can consider drug coating balloon, but for the bifurcation, the stent is something you should consider.
I'd like to ask Dr. Zaman. You saw a lot of calcification there. In your review of the DCB data, if it's heavily calcified, is it still suitable for DCB?
So this is the point I was going to make. That's a great question. So I think I'm surprised by the amount of calcium, and my feeling is that if we have optimal lesion preparation with a non-compliant balloon, the risk is of getting more complex dissection. So in my talk, I'll talk about the dissections. But if you have type A to C, you can get away with drug delivery alone. If the dissection is beyond grade C, and I think with calcium there is that risk, then I think for the main vessel, I think my a priori strategy would be that I would put a stent, because it's a much bigger vessel than I realized, and B, because of the calcium.
So, Sutek and Aaron, I'll get Tian San to unmute you now so that you can let us know what you intend to do and your ultimate plans so far.
Okay, so let me just hold off for the moment. So we are going to decide to DCB the RPDA. We'll let you know what we did for the PL branch later on. So we are going to DCB the PDA with a 225 by 15 balloon, which can go up to 2.5. So I thought it was an appropriate size. I mean, 2.5 on the angiogram looks pretty big actually. Yeah, I want to focus on the Prevail balloon. This is
maybe Aaron, you can tell us a bit about what DCB you're using.
That's Prevail. It's from Medtronic.
What is good about Prevail?
Eluting. This is a paclitaxel eluting DCB from Medtronic. Mounted on a more flexible, more trackable, and more pushable balloon. Yeah, using the Euphora platform of the balloon, and it has a slightly higher drug concentration of paclitaxel, and with the urea excipient that allow a very rapid transfer of the lipophilic paclitaxel into the vessel wall. And being lipophilic, the paclitaxel also stay to go deeper into the tissue and stay there longer. And hopefully the anti-proliferative property will reduce the chances of a restenosis at this particular location.
Thanks. So Sutek is going to show us now. I think this is the first time in Singapore we're using this Prevail platform DCB from Medtronic. So we'll see whether it flies in or not. Can I check with Dr. Zaman now? You saw the IVUS or Rosli. Is this the appropriate sizing you think for the osteo RPDA for DCB therapy?
Yes, I'm clear that it's the correct one-to-one sizing. Yeah.
Rosli?
Yeah, because if you see the vessel, the actual vessel size, lumen, not lumen to lumen, the intima to intima was about 2.5. So 2 to 5 would be just a nice size for this vessel.
Let me just test for you.
Yeah. So actually, it went in quite nicely.
Joshua, for you, when you use DCB like this, do you use a longer one? Is there any downside, or you will go with this length as well?
Yeah, I think for DCB, the current thinking is go longer rather than shorter to avoid any geographical miss. But I think in this case, there's an issue also with deliverability. We're going quite distal. And if we're thinking of doing a hybrid approach here, where we do DCB to the RPD ostium, I think this length is quite suitable because we will need to do some work on the distal RCA to RPL as well. So I think the sizing is also perfect because we use a 225 Wolverine. So I think it's appropriate, 1-to-1 balloon size.
Sutek, how long are we going to leave it up for this balloon?
It's 60 seconds, and I would like to seek your opinion. There's some data to say that you go beyond 1 minute, it might be better. The Korean group actually promotes 3 minutes. What do you think?
I will defer that question to Dr. Zaman again. He reviewed the data. Is it 1 minute enough?
So there are variations in practice. So my personal practice looking at the data is the key thing is that we have to avoid recoil. So what I do is I have 60 seconds up, and then I bring it down by 2 atmospheres every 15 seconds. So 1 minute at optimal, then reduced by 2 atmospheres for 15 seconds, further 2 atmospheres, further 2 atmospheres. So overall, I have the balloon dilated for around 2 minutes.
That's interesting.
I'm very happy that I have the same thoughts as you, because what I practice is again 1 minute. I go for 2, but I cut down by, let's say I go usually about 7 or 8 usual, because I go 1-to-1. And then I'll just cut down by 1 atmospheres every 10-15 seconds or so. and I'll be about 3 to 4 atmospheres by about 2 minutes before I go down. And this is basing on the fact, not because of drug, because as Dr. Zaman said that, you want to make sure that you've got longer drug inflation, and this is based on FOBA practice that we had before in the past.
And preventing recoil, that's the key thing, trying to reduce recoil.
Yes, you're right.
And all of you would have agreed, Gupta, with a scoring balloon approach before DCB, or do you think there's a difference? Can you just pre-dilate with a non-compliant and go with DCB, or must it be always some form of scoring balloon?
Yeah, thank you, Prof. Probably based on the imaging, there was a lot of superficial calcium in this vessel, which was quite circumferential, and I thought on IVUS it looked quite thin. So I think I would always prefer a scoring balloon or a cutting balloon, because one, it will not melon seat, it will not slip, so it will be where you want to dilate. And probably the severe dissections are generally less with the scoring and cutting balloons rather than a non-compliant balloon. So for a DCB strategy, probably scoring and cutting balloons are safer than a non-compliant balloon at high pressure.
Thanks, Gupta. Yan-san, can you unmute the Cathlab now? And then we have Sutek show us the result as well as what he's going to do with the PL before we move to the second lecture.
Dr. Tan, can I ask one question to Professor Lim before we move to the second lecture?
Yeah, go ahead.
Hey, Mohd. Yeah, Mohd. Nice to see you.
Professor Lim. May I ask you one question? So when it comes to the bifurcation, one question comes to my mind about the strategy. So should we do the DCB for the side branch first and treat the main branch, or should we treat the main branch first and then we just finish with the DCB for the side branch? Because in this particular case, if we do the cutting balloon to the main branch and we got a dissection and we need to put the stent in, so we have to do the rewiring to the side branch again and open the stud with the balloon. So if we do the balloon and we have the dissection, severe dissection in the side branch, so we have to put the stent in the side branch.
Thanks, Mohd. That's a great question, Sutek. So is it DCB site or post-stent as a provisional DCB stent? Sutek?
We actually discussed this question. I discussed this with Aaron before that. Either stent and then like what Mohd said. Then after that, the DCB, the side branch, if the side branch is not severely compromised. I thought that is also a logical sequence, probably a little bit better. And then we have a little bit more option after the provisional stenting. Yeah, but here we have some other consideration. Here we want to DCB first because after the ballooning, it looks quite okay. And then we actually went on to work on the RPL branch, and then we had some unexpected, some difficulty there. So we would actually like to finish with the proximal lesion first. But having said that, it is still possible to actually put a stent in first, and then rewire the PDA, and then do the DCB. I think there's a reasonable sequence. Aaron has a slightly different thoughts.
My concern is that if you really want to DCB the side branch after you put the stent in, and you know that the DCB balloon may not be so trackable, so it may not cross the stent straps. So and take a long time, and then the balloon may the drug may get lost in the system. So I think we decided we probably not going to stent this RPDA because the initial POBA result looks pretty good. So that's why we DCB first, and then we're going to probably stent the distal RCA, and then the PL branch actually we have very difficult to cross with the balloon. So they want to show the So we have great difficulties actually. It was a bit unexpected actually, but looking back, I mean, it was very calcified. So even one old balloon not able to cross. We have we tried the anchoring technique, didn't work, and then we have to put in a telescope right at the bifurcation. It did help a little bit, but it did not go as far as we actually wanted. Yeah.
So Aaron and Sutek, I thought you had an excellent result at the ostium of the RPDA based on your sizing and pre-treatment. Looks like very challenging. Can I ask Rosli, is this one of the cases where you think is best left medical, or would you try harder here for this RPL?
Yeah, I mean, I would try. I would try a bit. I know it's 1.0. It has not crossed. It crossed or it did not cross.
It didn't cross fully.
We'll show you where the balloon went. Yeah.
We wish to actually take Joshua comment that this RPL2 is not an interventional target and just leave it. but taking into consideration that the ejection fraction is down, so we hope to revascularize as much as possible, and hopefully the EF will improve.
Yeah.
Now, there is
it's a large PL. Perhaps if you really want to try, maybe a 0.85 Sapphire 3 would be good. Because once you've crossed and you dilate it, and you'll probably be able to work on it a bit better.
Yes.
Would anyone think that it's too far distal for rotablation here?
No, if let's say the vessel is quite large, 1.25 is still good enough.
Laser atherectomy also here would be very good. You've got the wire across, it's an 0.14 wire, and a 0.9 laser catheter would work very well here.
So I think we think that maybe we can try harder, Sutek and Aaron. We think that maybe some form of atherectomy we called for, or you upscale your guider, for example. So we're going to leave you for a while, and then hopefully you come back to see what you guys have decided to do. We're going to move now to the second lecture, and Dr. Zaman is going to talk to us about the use case for DCB in 2021. So we'll get this talk done first before I come back to you, okay?
Yeah, okay.
What do you think?
Yeah, okay.
So you have to unmute first and then switch the display setting.
Can you see my slides, or do I have to
yeah, can you click and just swap the display?
swap the display? Okay.
Yep, okay, now it's on full screen. Please go ahead.
Okay, great. Thank you. Thank you again for this invitation to come and talk. So the title of the talk is The Ideal Case for a Drug-Coated Balloon and the Update of Data in 2021. So what I want to start off with is a history of and the evolution of percutaneous coronary intervention. And what I thought actually that the title of this talk could equally be From Groinzig to Glagov. So the principle of when PCI started was we left nothing behind. It was just plain old balloon angioplasty. And that is how Groinzig pioneered percutaneous revascularization. The problem was they were early balloons, the materials were not great. And as you know, that those of us who were in this early era, a large proportion, 10 to 15%, had severe recoil that necessitated urgent coronary artery bypass grafting within the first 6 to 12 hours. The next evolution, and perhaps the biggest evolution of percutaneous coronary intervention, was the metal scaffold. We started off with thick struts, sirolimus coating, and now, as we've heard from the previous speaker, thin struts, everolimus, zoterolimus, and now we're coming back to sirolimus again. We had a brief flirtation with bioabsorbable scaffold. My personal feeling is that I think we will come back to this as technology improves. But now we're in a position where we have now improvement in technology of the drug-coated balloons, and we now have the potential to only leave the drug behind. So starting from leaving nothing behind to leaving metal to leaving bioabsorbable, we have now turned full cycle, and we have the potential now just to leave the drug only behind. So I'm quickly going to go through some slides of evidence for 2021. What is the trial evidence for large vessels? We had a debate, and it was very appropriate that we had this debate at the beginning of this meeting about how we define large vessels. And I think geography, where you practice, makes a difference. So for us, the median in this country is 3 millimeters. Anything below 3 millimeters, so 2.75 in Europe, is defined as small vessel. So when I looked at the studies in large vessels, there is this study from Rosenberg, published in 2019, looking at vessels, 234 vessels with de novo CAD with a cutoff of 2.75. The primary endpoint was the rate of clinically driven TLR at 9 months, and they compared those with small vessel, 2.45 millimeters a mean, with those that were 3.16 mean. The combined major adverse cardiovascular event rate was 5.7 in small vessels and 6.1 in large vessels for the DCB. Importantly, there were no thrombotic events occurred in each group, and the individual MACE component, the target lesion revascularization, was 3.8% in the small vessels and 1% in large vessels. So what this small trial showed was that in large vessels, you could safely use drug-coated balloons, and it had a very acceptable MACE rate that was lower than small vessels. There's a lot more evidence in small vessels, because this is where the drug-coated balloon has traditionally been pitched at, small vessels and, of course, in-stent restenosis. So this paper was published just last year, this RESTORE study, which was prospective, randomized, open-label, multi-center. Importantly, it had 2-year outcomes in native vessels that were less or equal to 2.75 millimeters in diameter. Importantly, the predilation or the preparation was left to the operator's discretion. But prior to delivering the drug, you had to achieve a stenosis in the vessel of less than or equal to 30%. And this is important because the message the drug-coated operators want to get across is that you have to prepare the lesion. And in my opinion, the name should be changed from drug-coated balloon to drug delivery balloons, because the message that we have to get out there is that these balloons are there for drug delivery only. You were allowed a bailout with BMS if there was severe intraoperative dissection, and I'll come back to that later. So the findings of this was that bailout stenting was seen in 5.2% of lesions in the DCB group and 1.8% in the DES arm. And there was a similar prevalence of dissection in both arms, and there were similar rates of device success, which is important because one of the things that we need to have is better delivery of the drug-coated balloons. So the device success was 94.8% for the DCB and 96.5% for the DES. Important data, and this is contemporary data. I won't go through the trial evidence for ISR because there are a lot of trials, and I've just listed them here with the publications. DCBs have been compared to a plain old balloon angioplasty for BMS ISR. They have been compared to paclitaxel drug-eluting stents in a bare metal stent ISR. They have been compared to everolimus DES in BMS ISR. And there was the burn group that compared to DES with the Taxus coating versus drug-coated balloon, paclitaxel versus POBA only. All of these studies were favorable, and they led to the ESC-EACTS guidelines giving a 1A recommendation for both drug-coated balloons and drug-eluting stents for the treatment of in-stent restenosis. So we saw the Prevail balloon being used in this case. First time it was used in Singapore. And the Prevail balloon is, I think, the first time that a company has looked at the drug-coated balloon market and seen that there is a growing market for this and that we have to make it more deliverable. So as we heard, it's based on the Euphora deliverable balloon, and it's recommended for in-stent restenosis and for small vessels, because 30 to 40% of eligible PCIs involve small vessels of less than 2.75 millimeters. Up to 12%, and in our practice, it's 7% of eligible PCIs involve in-stent restenosis following a drug-eluting stent. So use this balloon when stenting is not an option. What is this balloon? So as we heard before, it's a new technology. They call it the power track technology, which is combined with a hydrophilic coating to facilitate deliverability and device performance. The drug is paclitaxel, and the excipient on which the paclitaxel sits is urea, which is highly biocompatible and allows rapid drug transfer within 30 to 60 seconds of balloon inflation. So in clinical trials, there's very low angiographic plate loss of 0.05 millimeters with a low 4% TLR. And the selling point of this balloon is its superior deliverability, rapid absorption of paclitaxel, and its safety and efficacy. It would be remiss of me to talk about drug delivery and drug-coated balloons without addressing the point of dissections. And this is what operators are concerned about. And when I talk to my colleagues, it's simpler just to put a stent in because you don't get a dissection. So the important question is which dissections following balloon angioplasty and drug delivery should be stented. So this is a very simple case of a 68-year-old ACS patient that came in. You can see that there's a dissection of the LAD and there's a tight stenosis of the first diagonal. So the strategy was here to stent the LAD and to treat the diagonal with a drug-coated balloon. And you can see here after predilation, you have a type B dissection. It's important that if we're going to increase use of drug-coated balloons, that we understand the different types of dissections. And there is the NHLBI classification, which goes from type A to type F. I won't go through them all, but a type A dissection is a radiolucent area within the coronary lumen. Type B is a parallel tract or double lumen separated by a radiolucent area. And I hope you can see that this fits in with the definition of a type B dissection here that we have here. And then you have type C, which is a contrast outside the coronary lumen, and what you see is an extraluminal cap. And beyond that, you have D, E, and F. There is a correlation between coronary dissection after DCB angioplasty in small vessels and outcomes. And this study, reported by Funatsu et al. Recently, was a study of 171 patients, 228 lesions. And what they found was that they had dissection in 80% of lesions. We should not be frightened of this, because if we're going to have a DCB strategy or a POBA strategy, you will have dissection. The key thing, and those of us who do a lot of DCB, is that you then have to identify the type of dissection that you have been left with. In this particular study, they found that 38% were type A, 29% were type B, and a further 13% were type C or more. So the majority are type A or B. No patient required revascularization. And 159 of these 171 patients were followed up clinically for over 6 months. And target lesion revascularization was performed in only 7%. Follow-up angiography was performed on 143 lesions, and there was complete healing of all dissections. So in the 67% of patients with complete follow-up angiography, there was complete healing, and this is reassuring. The rates of restenosis and late lumen enlargement were 12% and 56%. And I referred to Glagov because what we see is flow-mediated dilation, where you get good flow and the vessel grows over time. And this is referred to as late lumen enlargement. And multivariate analysis subsequently identified that a lesion at a bend, which this particular case was an independent predictor of TLR. So this is important. If you have a bend, a C curve, maybe a drug-coated balloon strategy is not the strategy in that type. Type C to E dissections and imaging device use were independent predictors of restenosis. And lesions with type B dissection, A or B, had a larger net gain than lesions with type A or no dissection. So the message is leaving the dissection uncovered after DCB, and in this case it was paclitaxel, it appeared to be safe, resulting in a low acute event rate with type B dissections. So what did we do? So here we, the operator, which was myself, didn't feel comfortable, and we put a stent here. But the message is that in type AB dissections, if it's non-occlusive, then DCB strategy is good. But if you can see, this was on a bend and we didn't feel comfortable about leaving it. So what about the second lesion in small vessels and leaving a stent-like result? So this was a complex case, once again, in acute coronary syndrome, where there was a lesion in the LAD, a circumflex, and a trifurcation in an obtuse marginal. So the a priori strategy here was to stent the LAD, stent the circumflex, and to just have a DCB strategy, rather like the live case we have seen this morning. So if you look at the optimal preparation for drug-coated balloon dilatation, there is this several publications, and I'm going to talk to you about this one of 247 patients who underwent PCI using DCB alone for de novo lesions. Primary endpoint was target lesion failure, and IVUS analysis revealed that there was a residual plaque area of greater than 58.5% was associated with target lesion failure. So directional coronary atherectomy data from the Oars and Abacus study also supports a residual plaque area of less than 60% to have better outcomes post-stent. And what these studies guide us is that if you're going to use a DCB strategy, you must have good lesion preparation that leaves a residual plaque area of less than 60% before you deliver the drug. And it's a really important message to get across, that it's drug delivery we're looking at with the balloon, not preparation. You have to prepare the vessel first and then deliver the drug. So Jack and the audience, what is the ideal case for drug-coated balloons, drug delivery in 2021? Increasing evidence suggests that drug-coated balloons can be safely and effectively used in a growing proportion of PCI cases. In my opinion, these cases should be non-calcified, non-tortuous. Ideally, if you have long lesions where you can get drug in-stent restenosis, they are good for DCB. If they are small vessels, my definition, less than 2.75, you should think about drug delivery only. Recent evidence suggests that large vessels above 3 is safe to use drug-coated balloons, and of course the ESC gives a 1A indication for ISR. The message is leave nothing behind, and what I leave with you is from Groentzig to Glagov, the drug-coated balloon allows us to follow that cycle. Thank you for your attention.
Thanks, Prof. That's again a lot of data to chew through, but let's have a discussion. If you can stop your slide share. So I think maybe I'll start off the question with Kwang first. One of the main limitation of DCB, it is after all a balloon, and you have a dissection in a long segment, and you already spend the money because you use your DCB. How hard should you try for the bad dissection to salvage the DCB result, and what are the tips and tricks to say you can live with the dissection flat and to not end up with a stent? Kwang.
Yeah, so frankly, I have to say that is depend on how important the location of the lesion is. For example, like if the lesion is approximately LAD and usually we cannot, sleep well if I leave the dissect there, even if it is a type A or type B. So if it is an important position, and I think that I should finish the case very soon by putting a stent. But if the lesion is quite far away, and it doesn't matter how big site is, and then the area of the ischemic it is small, and then we try to fix the dissection by putting a balloon there, dilatation quite sometimes, and keep there for long, and it might heal the dissection or at least make it quite well. And if the flow is okay, and then I can leave the lesion there. So I think that for me, the first question is, should we, the first strategy is stent or drug coating balloon. If drug coating balloon, then we try to stick very closely with the strategy and try as much as we can by the balloon to fix the dissection. And we only keep like a 10 to 20% convert to stent if we need it. And I think it is my strategy, because everything you should decide it before you jump in. And if the location is important, then definitely for me, I should put a stent to make sure everything is okay, even the data is supportive. But however, the consequence, if it happens, is quite fatal. So that's why I don't dare to for the important location of the lesion. Yeah.
So thanks, Kwong, for that. I would like to ask Gupta now a question from the audience, as well as maybe a site-related question. Do you have any experience in DCB use in either a myocardial bridging stenosis or in the acute AMI setting? Your thoughts?
Thank you, Prof. Yeah, so I do not have experience of DCB in acute ACS, but I have experience in treating a septal LAD, which I think we discussed just 2 days back. So the patient had a remote infarction of the septal LAD. He had a dual LAD system, and then we had to salvage the septal LAD. And we did DCB, and of course there was dissection. We checked with the IVUS. There was dissection, but the area was more than 3.5 millimeters square. We did a DEB and left. But honestly, Prof, I don't know. It is sometimes very difficult for the young generation like us, who have always been trained on stents, to leave dissections behind, because we don't have the confidence that nothing will happen. So probably I will feel that I will do DCB only in a lesion which I can also do a bailout stenting. But I will try with a DCB strategy. And if there is a flow limiting dissection or there is something which goes wrong, I can at least bail out with a stent. So I will not touch the lesions that are absolutely impossible to stent. And then I do a DCB, do a dissection, and then have no option left behind. So probably it's for us, our generation, it is more difficult to adopt DCB than Dr. Zaman and yourself, who have had the experience of treating without stents.
Dr. Zaman, your comment?
Just one comment. So both operators have talked about either or DCB or stent. The time to make that decision is when you've prepared the lesion. So you've prepared the lesion in the normal function with either an NC or a plaque scoring balloon. And it's at that point you should make the decision whether it's DCB or a drug eluting stent. So you shouldn't be going from drug-coated balloon delivery to a drug eluting stent in normal circle. Make that decision after you've prepared the lesion.
Thanks for that. Again, that's very good advice. Rosli, do you have any advice about the myocardial bridge? Do you have experience in using it there?
Yeah, myocardial bridging, yes, I suppose this is an area that you don't want to stent. You might want to give if it's really indicated. But if it's bridging per se with stenosis, I don't think there's a role for any treatment at all. But can I come back to the point of the stenting? It's all a matter of confidence. As what Dr. Zaman said, it's all about the preparation. There will still be a slight, reverse. A conversion rate to a stent, yes, but you want to limit that. So the preparation is very important. I would want to consider DCB if it's possible for all lesions except left mid. left mean I'll be a bit, hesitant to it. But even if large vessel, if you prepare well, you say, hey, the result was quite good. And you may want to pick it up DCB. Sometimes I would, in case that I'm not sure, I would just wait for a while and see if the flow is still good, then yes, you can go. If you look at the current recommendation or guidelines, you will find that they don't say type A or B dissection. No, it is a dissection that will not impair flow. That will probably be until C. So as long as you find that there is no impairment in flow, you would want to use DCB. And in fact, I look forward if I were to see dissection. And if it's non-flow limiting, the reason is because if you have a dissection, you'll be more assured that your drug will penetrate, and you know the paclitaxel goes right until close to adventitia, and it goes deep. And when it heals, this is where you find that vessel dilatation will occur, positive remodeling. And this paclitaxel is better than sirolimus-eluting stent in terms of obtaining vessel dilatation. So it's a matter of trying to get confidence. The more you do it, and you find that really it's like old days where POBA is used that for type A, B, and even certain type C. If you have got good flow, you can sleep well at night and it will not close. The problem arises if you put a stent and there's an edge dissection, that you've got to be very careful, because then the risk of thrombosis is much higher. But when you put nothing behind, a good flow, and you've waited for a while just to be sure, you can bet your bottom dollar this vessel will not close. Hopefully it will heal and it will grow.
Thanks,
Jack,
Doctor.
can I make
Obviously, there's a generation gap there, but we'll ask the younger generation to respond to that. Gupta, please.
I just also was discussing there are some operators who would like to do a FFR after they've done a DV or after they've done the vessel prep, and to see if the pressure gradient is more than less than 20, if the FFR is more than 0.8, then it is likely that this vessel will not close. Just like when Andreas Brutzing used to do, they used to have intracoronary pressure measurements pre and post stenosis. So if the FFR is good, then the chances of acute occlusion are less. I don't know how much of this approach is also being used in the DCB trials to do a final FFR and decide. But yes,
if I can say something, yes, I think that's something that you may want to pull up. There are data to show that's more than 0.8. If you wait for a while, it will not close, especially you look at angiographically and you look at FFR, it gives you great confidence. The only thing I may suggest, and I try not to do it myself, is do not pull out imaging, because if you pull out imaging, you find more dissection than you were concerned about it, and you want to put in stent. I think for DCB, you want to get away. You look angiographically and look at the flow, which is very important. And and if you see a dissection, is flow. If you don't see a dissection, is recall of more than 30%. Then these are the cases, and we have even personal experience. These are cases that will come back with restenosis. So the guidelines are good because it helps you to decide how to use DCB. I encourage you to go through and practice. That's the most important thing. Practice to gain confidence.
So we'll go to a comment by Prof Zaman, then Kwang.
Yeah, so what I would say is that poor old Andreas Groenzig lived in the era of aspirin and warfarin. We now have dual antiplatelet therapy, so the risk of acute closure is reduced, and the balloon technology is far better. But you say about FFR, what FFR cannot tell you is what happens 1 month, 2 months, 6 months down the line. And once you have less than 60% plaque lesion and flow, the flow-mediated dilatation, which is a fantastic case that you saw that Dr. Ali showed in his case, flow-mediated dilation after a few weeks, few months, makes that vessel grow. So I would say the same advice. I don't do this for every, but I think we can use DCB for around 25 to 30% of our total PCI volume, and that's what we should be aiming for.
Kwang?
Yeah, I just want to raising a question about the how the calcification impact on your decision, especially when you see the dissection. So, for example, like if after you put the drug coating balloon and then you got a dissection and the lesion, you got a calcification there, and how you can predict the future for the dissection. Is it easier to become a thrombus more than the normal vessel without a calcification, or it more stable? So what do you think about that, Dr. Asli and Dr. Zasman?
I believe it's all, again, a matter of preparation, because once you vessel prepare in a calcified vessel, you have to see the results. If the results are not good, you will have to prepare the vessel very well for either for DCB or even with atherectomy devices or other non-compliant balloons. So it's really a matter of not just dissection per se, but also the residual restenosis. Those are important points. In fact, when I start now to use OAS and even with IVL, the results are quite good enough that it's quite likely they will end up with DCB. And that's something which is good, because you want to make sure that the calcium fracture, and this drug can go into very well, and the results was much better. In de novo lesions, I find that a cutting balloon gives much better results as compared to scoring balloon, and obviously compared to normal balloon. You tend to get more pleasing results in terms of vessel preparation, so much so that you can actually pull up DCB. Zaman?
Yes, no, I would agree with you, Dr. Ali. I think where you see angiographic calcification, you must take IVUS. And then I think the arc of calcium, the degree of arc of calcium should determine your strategy. So if it's 270 and above, I would never use a DCB alone strategy. I would score. If it's less than 180, then I would think, if I've got a good result after lesion scoring, then I would use a DCB strategy. So I think assess the calcium. If it's greater than 270, for me, it's preparation and stent. If it's less than 270, I would then make the assessment after lesion preparation.
Thanks, Dr. Zaman. I would like to now go to Joshua. We heard the update on the data, but there are a lot of data, like today's DCB was paclitaxel. Well, what is a read on the difference between a sirolimus-based DCB versus a paclitaxel-based DCB? Which one is your go-to DCB in 2021? Joshua?
Thank you. I think you raised a very valid question. And frankly, we do have the majority of our data with paclitaxel. The reason why paclitaxel is actually suitable for this drug delivery using a balloon is because it is highly lipophilic. So on first contact with the vessel wall, the drug is immediately delivered and stays there as a reservoir. The problem about limers-based technology is that they are not lipophilic. So you do need nanoparticles to actually facilitate the transfer. So far, I think there are a couple of players in the market and with small data, but I must say that none of it has been convincingly shown to be better than the paclitaxel-based balloons. And so I think the utility of moving forward with limers-based technologies is still in question. So therefore, even with this Prevail balloon, they're using the paclitaxel technology with a very good urea coating, which can actually deliver the drug efficiently with an improved delivery system. So I think paclitaxel is here to stay, at least for the DCB arena, until we have a better and more efficient way to deliver the limers drugs.
Thanks, Joshua, for that. Dr. Zaman, your ESC guideline, that the 1A indication for ISR, they don't state whether it's a paclitaxel or sirolimus DCB, do they?
No, they don't. But as Joshua said, the great majority of evidence is for the paclitaxel balloon. Now, paclitaxel got a bad rap with the Taxus stent. And therefore, for drug-eluting stents, there is absolutely no doubt that the Olimus group of drugs has taken over. But I think for the drug-coated balloon market, the evidence basis for the paclitaxel-eluting balloons, the evidence for the sirolimus, we will get over the next years.
Thanks. I would like to have one last question from Dr. Moonpat before I go back to the Cathlab. Dr. Moonpat initially talked about always having imaging to make sure that it's not truly a small vessel. So it's very tempting then after DCB to go back with imaging. And you have a long calcified dissected segment. You don't have FFR, the flow seems good. You see a lot of dissection. Can you give us some pointers on imaging? What are the things that you need to go back and patch up, or things that we worry about on your imaging? And when you want to use DCB, is it still safe to use a high flow OCT injection if you're using a DCB strategy? Dr. Munpet.
Thank you very much. So for your second question about the OCT, I don't have the good answer, and I am going to ask Dr. Zaman or Dr. Rosli about this. That after we do the DCB, can we do the OCT or can we do the balloon dilatation again? I don't have the answer for this, and I want to ask. But for the first question about imaging, I have a different opinion. I think we should do the imaging. And for me, if there is the intimal dissection, I'm very okay and happy. But if we got the medial dissection, even the flow is still good, there is a risk for the expansion of the medial dissection into the medial hematoma, and if the hematoma expands, we can get the obstruction of the artery later. So if I got the medial dissection after DCB, probably I would do the bailout stenting. But if I have just the intimal dissection, I'm very happy and I can sleep well with that.
So even if the flow is good, if you see medial dissection on imaging, you're going to stent. Is that what I'm hearing from you?
Yeah, if I saw medial dissection and no, if it's a small medial dissection, maybe okay. But if you see a large medial dissection or medial hematoma, I would do the bailout.
That's interesting. Sometimes medial hematoma is also visible on angiography, but if the flow is good, do you necessarily need to stent them? Maybe one last comment from Rosli, then we have to really get back to the Cathlab. Sorry.
Okay. All right. So the most important things I say is the flow. If you see dissection, talking about dissection, not residual stenosis. Sometimes what I do is, if I say there's a lesion, I treat that lesion first. And when I treat that lesions, there will be some time before you want to see the results after your balloon angioplasty. If let's say that the flow is not worsened after 5 minutes, then you always be sure that it's not going to close off. The longer it is that you wait, for example, you do other lesions, you come back after 40 minutes, it's still the same, you can be sure that it won't close off. I think we have seen this in the past. We've seen this over the years. This is what it is. That's what balloon angioplasty is. As I said, the concern will be if let's say I put in the stent and there's edge dissection, that I will be a bit definitely more hesitant. But if let's say there's nothing left behind, the flow is good, you waited a while, then you will be able to sleep well at night. I can almost assure you that.
Let's see what the Cathlab is going to show us, whether you're okay with the result or not. So, Yin-san, let's share from the Cathlab and hear from Sutek. Sutek and Aaron, we're back with you now. We can hear you. So, would you like to share with us the journey?
The BB?
Okay.
Yeah. Okay, Jack, thanks.
No, it's a guideline. You take it out.
Huh?
Guideline.
Okay, take it out first.
Yeah. Okay.
Yeah. Okay, just now, you left us when
we left you when they have problem crossing the RPL branch with even a 1O balloon. It was heavily calcified. Rosli say, don't stop. He wants to get it done. While maybe Josh and me say maybe can leave alone. But we'd like to hear from you what you've done so far.
Yeah. So you can see that actually this one was an earlier phase. Yeah, we have the guide extension catheter in the RCA, but we could only manage to advance this to the bifurcation of the RPDA and the RPAVG. 1 millimeter balloon couldn't go, but yeah, there's a maximum that 1 millimeter balloon could go, but then we put a 1.25.
1.5.
Sorry, 1.5. Then this is the furthest that it could go. This is at 220 millimeter length balloon. So we actually dilated the back here, and then this is after the dilatation. Yeah. Then after that, we dilate the ostium of the RPDA with the trivial drug-coated balloon. And after that, it looks quite okay, but a little bit of spasm distally. And follow on short after that, the spasm improved a little bit after GTN. After that, we decided to stent the distal RCA to the RPAVG, the AV groove branch, and then put in a Rosli Onyx 3.5 times 22 millimeter drug-eluting stent, metallic drug-eluting stent. And then we pot it with a 4 millimeter balloon here. And then the flow was not, the flow in the RPDA, get a little bit compromised. Yeah. And then we pot again. And then eventually we managed to get the Sion guide wire into the RPDA. And then we did the modified kissing balloon dilatation with a 3.5 millimeter balloon in the RCA to RPAVG, and then 2.0 in the RPDA. And then with the finer pots, the pots and repots. Okay, this is how it looks like. The RPDA flow improved. Yeah, it looks okay. I think Dimitri flow not. And now we decided to remove that wire to get this guide extension catheter into the
Right to the end.
Right to the end in the AV groove R3. And then Aaron just tried the 1 millimeter times 6 millimeter, 1 millimeter balloon. Yeah, couldn't go across the calcified part. Yeah, the band that is calcified. So it has. We have tried 3 1 millimeter balloon and then 1.5, I think. 1.5 that could go a little bit further. Anyone know of a more pushable, small profile balloon that thing can go past this?
Sapphire 3 0.85. Beautiful balloon.
So Rosli suggests a Sapphire 0.85.
We only have actually the Nick Nano, not so much the Sapphire. Only
we have Nano is very poor in terms of pushability. So even the 0.85 is very poor, and that's good.
Yeah.
But the Sapphire 3 is beautiful.
We have 510.
Oh, we have, yeah. Rosli, we will see. Yeah, we have 0.85.
So anyone has comments about the guiding? Do you think this guiding, this JR4 guiding with guide liner all the way to the bifurcation is equivalent to more active support?
Let's get the 2.0 first.
Dr. Zaman?
I think with the guide liner, I think it gives you ample support. The other option might be use a Corsair or a Turnpike Gold microcatheter to get through the lesion and then the balloon.
Kwang, when do you decide to stop? Do you think when is this something you continue?
I think it is a great question, because for me the most important thing here is try to keep the flow in the RPL and to keep the ostium of the RPDA as much as to open as much as possible. So I think at this point I will continue try a little bit further, see whether I can dilate a little bit more, because for the long run the ostium of the RPDA might affect on the outcome. So I will try a little bit further. I do not stop at this point, I think.
Joshua, would you have decide when to stop?
I think these attempts have
Yeah.
shown itself that perhaps should not pursue any further. Yeah, I'm not entirely sure about the distal vessel size as well. So I'm not sure if even if we do stepwise opening up, whether we can actually achieve a good result.
That's what we show you this one, particular one. Yeah, you see the distal end, Yeah, you see that the RPL1, RPL2, not that small we thought. So we thought it's worth a try, but it's a very long segment, but it's calcified.
It's very calcified. Yeah,
it's calcified.
So you guys have gone in with the 0.8 balloon, 0.85?
Is that
right?
Coming. Yeah.
Okay, so we are.
That's our Rose prediction.
Yeah, we see whether Rosli's suggestion helps with more pushability.
Go, Aaron, go.
Actually, before the case, I was discussing with Aaron whether to use the unplugged catheter.
Is it coming out? Cannot see the eyes. Yeah, okay. Stuck there here. No, it can't go.
Rosli, do you happen to know whether the shaft, the pushability of this balloon compared to say
because
slightly bigger balloon?
Yeah, I
slightly
think
bigger balloon.
It's a very good balloon. It's a very good balloon. There are two things. Number one, I find that for extension microcatheter, I love the Guide Plus 2 by Nipro. It's so soft, it goes really deep in, much deeper than the others that I know of. Secondly, if you can, I think in the end, we have got to be philosophical. Sometimes it's best not to do anything we cannot get, we need to know, as you said, when to stop.
So I think what we do is we use a 1.5. The 1.5 balloon actually went in quite far. So I think it went into just before that branch. So I think we can use a 1.5 to dilate the more proximal part, and then we can leave the distal alone. Yeah.
And the new one?
Yeah, can we have a new 1.5? Yeah. The pressure is damn with the guideliner so deep in, so we have to probably do it quite fast. Yeah.
So this part that was always the toughest, knowing when is erring on side of safety. You have to probably know yourself in the case. I think there's a lot of diffuse disease along the whole segment of the RCA before you even reach the lesion. So as you put more equipment in, there's more risk of course, damage to the proximal RCA as well. Any other faculty advice for Aaron and Sutik?
Anyone want to try the toners for this type of thing or not?
20.
I see a lot of people shaking their head. I'm not too sure why.
Okay.
Maybe Rosli, you have bad experience with toners. Is that why? Or
no, not really. I think once you want to use in this sort of vessel, which is about
1.5, 20.
If quite distal, I am not
15 can also.
Not very keen anymore.
Okay. Rosli, are you still keen on the rotablator?
What do you think the size is looking at that? If it's a 2.0, then yes, perhaps, but
maybe 1.75. Maybe 1.75.
Yeah, I think until you know the size, it's difficult to select a burr. I would go with a microcatheter. Outside a Coursera or a Turnpike Gold, which will get you through, which is safer than a tonus if the balloon doesn't work.
But once we tunnel through the, what shall we do with the microcatheter?
Prof, can we jail the microcatheter and change to a more support wire like a Cyan Blue extra support or a Grand Slam?
Cannot go.
Yeah, once you get the microcatheter through, you often a balloon will go through, but exactly that point you can then change to a more supportive wire.
This one cannot.
What's the 1.520 balloon? 20 balloon?
So my own personal experience is that sometimes I just stop at this stage. I will bring the patient back, and the primary approach then will be to rotablate it with 1.25 atractomy, because if I can't cross with 1.0.8, one option is to change out, of course, to an unplugged type. with more support. But as you step up, there's a high risk of complication, and I think I might just defer and come back again with a primary atherectomy, and then check all the other sites that have recently intervened. That's one option.
That's a good suggestion, Jack.
Yeah, but I'm a little bit concerned about the doing atherectomy because the patient's EF is down, and if it causes no reflow or perforation, it'll be a quite a high risk procedure. Yeah, and it's not very big branch.
Yeah, you know, when I look back at this, I'm also a bit hesitant about wanting to do atherectomy for this. It's really far down. Of course, I had a bad experience also of a perforation, and this is where you know, in really small vessel, the risk of perforation is much higher.
Yeah, I agree. I think you really have to balance the risk and benefits here. It looks like it's a single branch of a dominant artery. We should try with a balloon as we're doing now, perhaps, Mike, but I wouldn't do rotablation.
Can I ask? This is a guideliner, Aaron, or guide class or telescope?
Telescope.
Can a 1.25 rotablator fit inside this telescope? 6 French?
No.
Could be.
No. The size actually fit, but because there's a the what we call the ribbon. Yeah, the burr itself fit, but because of the ribbon, there we tried before. Yeah, it
didn't cross. The 1.25 can't cross. Rosli, have you tried before to a guideliner 6 French 1.25?
Yeah, guideliner, yes, 1.25 it does cross. I think you should be right, but I would presume it should be the same with telescope.
We actually tried test it out outside. It can't go. It can't go.
So
I've tried in a patient before with a guideliner. Yes, it does. It is a
guideliner. Yeah, guideliner
may be
okay.
different.
Yeah, guideliner. Okay. Yeah.
So, today, Aaron, we're going to come back to show and let you work in peace later on back, but I have to close the session at 5. So we're going to have Yan San to stop share from the Cathlab, where we go back to have a summary discussion with faculty. Then we'll come back to you to let you play out. So thanks a lot. We'll come to the last. Thanks, Sudhir, and thanks, Aaron, for the hard work. I think the patient will really have benefited from what you've done so far for the right and the LAD. So hopefully you have a good result and see what you stop and do later. So we have the last 10 minutes. I would just like to get my faculty to provide their one teaching point and closing statement for the audience before I summarize. So we'll start with Dr. Kwang first for your one teaching point. You have to unmute yourself, sorry.
Yeah. So I think that one thing is important for the PCI for the small vessel DC is we try to do as safe as possible, because somehow when you facing the small vessel disease, you're facing a very diffuse disease, and usually the patient somehow in you call like an end phase of the coronary artery disease. So we try to as safe as possible, and drug coating balloon is something is safe, and also got a strategy like left nothing behind. So I think in principle, drug coating balloon is a very good option for the small and diffuse vessel disease. However, we always consider that optimal medical treatment is there, and we should optimize everything before you jump in the very diffuse and small disease, and also contain a lot of risks of dissection behind. Yeah.
Thanks, Kwang. Joshua?
Yeah, I think we live in an era that actually there are treatment options for drug for small vessels, and that being drug-coated balloons or small ultra-thin strut DAS. But I think the key to decide on the therapy is the lesion preparation, and the decision will have to be after your initial lesion preparation, to decide which of these therapies is more suitable. So according to the DCB consensus statements, if you have a flow limiting dissection, residual stenosis of more than 30%, or if you do a FFR and it's less than 0.8, then perhaps you should consider DS rather than DCB. Thank you.
Thanks, Gupta.
Yeah, I would also think the same, that we should go stepwise and take our final decision after the pre-dilatation and not before it. And when we are building our experience in DCB strategy, try to avoid lesions which are very calcified.
Thanks, Gupta. Also a very strong point. Munpet?
Yes, I think my point is optimal lesion preparation is essential in using a drug-coated balloon. And in the small vessel disease, I think DCB is the good option, and it has a benefit in terms of the easier of the delivery, and maybe it's provide a more homogeneous drug transfer to the vessel in the small vessel disease. So and of course it's left nothing behind, and there is no risk of the stent thrombosis. So I think it's a good option, but we need optimal lesion preparation.
Dr. Zaman?
Yeah, thank you, Jack. So number one is, if you're going to want to increase your use of drug-coated balloons, number one is prepare the lesion. Number two is learn to assess and understand angiographic dissections. Number three, you need to understand that angiographic dissections have been validated in terms of outcomes. So you learn to understand and place those angiographic dissections with outcomes. A to C is good, you can leave. D to F, you may need to stent. And the fourth point is that these are drug delivery, and the balloons are used just for drug delivery. And if I can just make a final point, I'm not a fan of using FFR to whether to make the decision to stent there or not, because what the drug delivery and a good lesion preparation will do is they will allow the vessel to grow. So remember Glagov, after 6 months, flow-mediated dilation will mean that the vessel has grown. So I'm a little bit cautious about using FFR at the point of delivering the drug and then making a judgment at that point. Thank you.
Thanks, Dr. Zaman. I always leave you with a second last word, Rosli, so maybe you can summarize.
Well, summarize. Well, nothing more to add with regards to DCB and so on. But I feel that it is a technology that it's coming into on board. The notion of leaving nothing behind is very attractive to me. And what is better place to actually practice this than in small vessel, because there's data to support small vessel disease. And once you gain more confidence, then you can go on for a much larger vessel. So it's a matter of practice, gaining confidence. The only thing is that you've got to be more patient when you do DCB. DS is quick, but it may not. If you can get something better like leaving nothing behind, I would suggest strongly to have that. And specifically for small vessel disease, this is still a challenge. Can you imagine drug-coated balloon is being tested in very high risks of events and poor outcome in ISR in small vessel disease, and is beginning to stand out, and that's something to me very interesting. Thank you. Thank you, Jack.
Thanks, Rosli. So I heard a lot today. I just like to quickly summarize my own thoughts for the session. Firstly, by thanking my participants, my faculty, and of course my bosses for showing such a challenging case. They picked the case, not me, so they can't blame me as well. I'd like to state initially our learning objective is small vessel disease. What I've learned from everyone is that small vessel doesn't mean small necessarily. Small could be just small and diffuse, which I think, although Dr. Zaman has the pleasure of working with trio vessels most of the time in Asia with diabetic prevalence, here we work with much smaller vessel subtype than him. So it is truly challenging, particularly in Asia. So we do have to learn how to deal with it. I also heard from everyone that imaging might be important. It changes your decision process in these cases of how to tackle diffuse small vessel disease. And of course, don't neglect optimal medical therapy like what Professor Kwang mentioned. That's highly important in a diffuse disease subset on top of maybe better antithrombotic, antiplatelet agents. The DCP part, I'm a bit more nuanced. You saw the major guidelines. They say there's a class evidence for use in ISR, but the other subtype, they keep silent because the data for those are still pretty weak. I think if you look at the largest study, basket small, for example, in small vessel and small is 2.75, the crossover to a requirement for stent, in spite of the fact they try, is still at least 40%. So in a lot of times, you may not get a good enough result or get significant dissection in this particular subgroup of diffuse disease that you have to cross over. So it does increase cost, but if you do get it, and you do get a good, nice stent-like result, I think you can almost guarantee a good result long-term as well. So I think the answer is somewhere in between. I think there's still not enough data to apply across the board to have no stents left behind. There's less data on maybe a stent bifurcation kind of approach, which a lot of people talk about, but we still don't have enough data for. So in this day and age, I think it's still good optimal medical therapy, drug-eluting stents applied properly, good lesion preparation, DCB in selected cases for this small vessel degrees subset. So with that, I'd like to thank everyone for their time, and I'd like to end sharp at 5 o'clock. We will then go back to the live case and then see whether they will show us how they are finishing up. And I will let the live stream go on and for them to show us and conclude, but everyone else can drop off if you like at 5 o'clock. Thank you very much for your time. So Sutek and Aaron, we're back to you.
Yeah.
And you're going to run the rest of the session and tell us what you're going to do. Although the session
we are finishing.
Okay.
Yes. We decide to take your advice, and then after this, we tried the balloon. Yeah, we couldn't cross with 0.85, 1 millimeter, 1.25. And then after that, we give one more try with the tonus, 2.6 French tonus. Yeah, the tonus actually could be advanced only to this point. This is the point with the heaviest calcification. Yeah, and it gets stuck there and couldn't advance anymore. Yeah. So so we decided to end the procedure. Yeah, you can see that actually, the tonus also got stuck at the calcified area. Yeah, inside the calcium. Yeah, and then we have to pull it out, and then we have to retrieve the guide catheter just to make sure that it doesn't injure the ostium very much. So this guider has gone in and out of the proximal RCA very much. A number of times. We have to be a little bit careful. So this is the last shot that we have. And I think RPDA, the ostium look a little bit hazy, but we'll see how it subsequently evolve. And then hopefully the positive vessel remodeling will help.
Yeah, I think
whether to come back again. Yeah, whether to come back again to try with your atherectomy, I think we need to think 3 or 4 times first, right?
I think for what you've done for the LED and this artery, let's see what the EF does, whether it's truly compliant with medical therapy and his risk factor control. Then I think you can gauge whether you want to come back and tackle this RPL branch. I think the risk benefit, like you rightly put it, may or may not be there. So we shall see. We'll keep at it.
Thank you very much. I'm sorry that we chose such a case that we are not able to achieve all the objective, right? Actually,
no. I think you did help us achieve all the objective, Sutek and Aaron, and this really is the limitation of small vessel, especially in the calcified subset. I think what you did was very sensible, without causing any further harm to the patient. So thank you very much. To the Heart Center Cathlab, and thanks to Sutek and Aaron, my bosses, for trying out this.
Like Jack, you are now the boss, Jack.
Yeah. Thanks a lot. Thank you very much.
Thank you. Bye-bye.
Yeah, bye-bye.
Very good case.
Thanks, everyone.
Bye.
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 I think enough.
Enough.